We're going to hear from three research residents today. First, Dr. Kate Carroll, then Dr. Jessica Eaton, then Dr. James Pan. They're going to spend about 15 minutes on their talk, so please try and stay on time, and that way we'll actually have a chance for questions. We'll start with Dr. Carroll, who has a much more interesting history than I think we all thought, but went to her undergraduate degree at Princeton, following in Dr. Jeffrey Oden's footsteps, and then medical school at UCSD. And so she is a member of the SANS lab, and her project is a very interesting one, and I will leave it to Kate to go ahead and start.
Okay, can everybody hear me and see my slides?
Yeah.
Yes.
Okay, perfect. Thank you for the introduction, Dr. Levitt. I'm going to talk today about the work that I've done over the past year as part of my dedicated research year. The title of my talk is The Role of Corticotropin-Releasing Hormone Receptor 1 Genotype and Hypothalamic-Pituitary-Adrenal Axis Dysfunction in Depression After Aneurysm Rupture. This work was awarded an R25 grant. So our aneurysmal subarachnoid hemorrhage patient population is doing much better these days than it was 50 years ago. Survival has improved, as has functional recovery, but as patients are living longer and doing better, we are seeing a rise of psychosocial sequelae. In a recent meta-analysis published in 2020 on 55 studies, with over 6,000 patients included, they found a pooled frequency of depression of about 26%, a weighted frequency of 28%. Depression ranged from 0 to 62%, was assessed from anywhere between 4 days and 10 years. As you can see, it doesn't change significantly from the acute 1 year after ictus period to greater than a year afterwards. It typically ranges from mild to moderate. And the meta-analysis found that some risk factors held up across multiple studies, including a prior psychiatric diagnosis, as well as aneurysmal etiology of the subarachnoid hemorrhage. They did not find that there was any association between age, neurologic outcome, and treatment type. And then some variables still need further investigation. These include sex, race, presence of an infarct, cognitive impairment, disability, and fatigue. Why should we care that our patients suffer from depression? The meta-analysis further showed that depression significantly correlates with rates of unemployment and with worse healthcare quality of life scores. This study, retrospective cohort study performed at Rush, showed that patients who were unemployed 6 months after aneurysm rupture had a rate of depression of 38% versus those who were employed who had a rate of 6%. So how do we treat our patients? How do we get them back to work and having a better quality of life? There's really very little data within our patient population. There's one prospective study on the treatment of depression and anxiety after subarachnoid hemorrhage, and this looked at the use of mindfulness-based stress reduction techniques, which does significantly improve depressive symptoms and brought participants' overall depression scores from moderate to mild. We know from the post-ischemic stroke depression literature that antidepressant use is an effective means of both treating post-stroke depression as well as, importantly, prophylaxing against the development of it. That information is being translated to the subarachnoid hemorrhage population, but the evidence isn't published yet. What we do know from research is that patients with aneurysmal subarachnoid hemorrhage are being treated with antidepressants. This study in Finland looked at subarachnoid hemorrhage patients a year after their ictus and found a rate of antidepressant use of 30% versus a matched control non-subarachnoid patient population, which had the kind of typical antidepressant use of 14%. So we know that our patients are becoming depressed or at risk for depression. We know that treatment is effective, but treatment is not innocuous. This is from the package insert of Lexapro, listing the most common side effects, not the most significant side effects. And I think that we can all agree that none of us would actually choose to experience this. Which begs the question, can we identify a subgroup of subarachnoid hemorrhage patients who are really the patients we need to target in order to prevent the majority of depression? And that is what a group led by VetCast tried to study. And they looked at how genetics might help us identify at-risk populations. This study was a retrospective cohort study. They included all surgically treated ruptured aneurysmal subarachnoid hemorrhage patients who presented to a single institution from over a decade, and they identified 125 patients for inclusion. Then they prospectively interviewed these patients and used the emotional state questionnaire to assess for depression. This was done at an average of 4 years after aneurysm rupture. And at the same time, they took venous blood for genotyping. And what they were specifically interested in is corticotropin-releasing hormone receptor 1 polymorphisms and genotype, and how it related to aneurysmal subarachnoid hemorrhage mental health. This was their distribution. They looked at 3 polymorphisms and showed the allelic distribution. In the first study that they published on this, they looked at depression and fatigue and insomnia. They found that the minor allele in one of the polymorphisms significantly correlated with less depression, so was actually protective against depression. And this was significant in univariate and multivariate analysis, but fell off after Bonferroni correction. Similarly, minor alleles were protective against fatigue. And in a second paper they published with this same patient population, they looked at quality of life scores, and similarly found that minor alleles were significantly correlated with improved healthcare quality of life scores. So just to really drive this point home, if you look at the allelic distribution from homozygous for the minor allele to homozygous for the major allele, you have almost a dose-dependent reduction in quality of life scores. So to make it really simple, minor alleles are protective against depression, major alleles appear to be correlated with increased risk of depression. Why were they interested in CRHR1? What makes this a relevant target? As a little bit of background, here is the hypothalamic-Pituitary-Adrenal axis represented in homeostasis. But from decades worth of research, we have found that this is disrupted and dysregulated in patients with chronic depression. How so? We believe that the glucocorticoid receptors, after prolonged stress, after being subjected to prolonged stress, become desensitized, which results in increased corticotropin-releasing hormone and increased levels of glucocorticoids. This is seen specifically in the CSF. A lot of the research was done looking at CRH levels in CSF. Patients with depression have abnormal low-dose dexamethasone suppression test values that normalize when patients are adequately treated. They have decreased CRHR1 expression in the anterior forebrain. And this has led us to believe that some of the dysregulation might be happening or varying at the level of the CRHR1 receptor protein. And so they've looked at genotypes of CRHR1 and found that in multiple populations who have experienced a trauma, that it is correlated with an increased risk of depression. This has been looked at in subjects who have survived a hurricane, in patients who have had medical surgical ICU stays, and as I discussed, in our aneurysmal subarachnoid hemorrhage patients. Bringing this all together in the post-ischemic stroke depression literature is this model of how our trauma, how our cerebrovascular event winds up causing depression. Obviously, it is multifactorial, but the pathway that I was interested in is this one, that something about an aneurysm rupture, a stroke, subjects the body to increased stress, which winds up resulting in dysregulation of the HPA axis. It appears to be modulated by reduced BDNF transcription due to the elevated corticotropin-releasing hormone, and that may happen at the CRHR1 receptor. And this ultimately leads to post-stroke depression. What I was specifically interested in looking at is how CRHR1 genotype impacts HPA axis behavior after a trauma, and then how the dysregulated stress response impacts risk of depression. So in order to further investigate these two questions, we have started a single institution observational cohort study. Our goal is a sample size of 30 patients, as this is really a feasibility study to better inform a larger prospective study. We are including patients who are adults, have the presence of a ventriculostomy, as we're taking samples of CSF repeatedly. We excluded patients who presented with a Hunt and Hess grade of 5, as these patients have a very poor prognosis. Unfortunately, we had to limit our sample to English speaking only due to resources. And then we decided to exclude anyone who presents after 48 hours because we were really interested in capturing that acute period after rupture. We excluded non-aneurysmal subarachnoid hemorrhage patients, as well as patients who had an infectious or traumatic aneurysm, as the pathophysiology of these two patient population differs from the aneurysmal subarachnoid hemorrhage patient population and may confound our stress axis results. Our study design is as follows. Once patients are admitted to the hospital, really at any point during their hospitalization, we take a portion of a serum sample and process it for later polymorphism and genotype analysis. At 4 time points during the first 2 weeks of hospitalization, we take CSF and serum samples that are processed and stored for BDNF levels and CRH levels. We're taking both CSF and serum because, as I mentioned, a lot of the data in support of the hypothalamic-pituitary-adrenal axis role in depression used CSF as used CRH in the CSF as a biomarker. But if we can establish a correlation between CSF and serum, serum is obviously less invasive to collect than CSF. Once patients have exited that acute critical care phase, we have 3 points of follow-up at 6 weeks, 6 months, and 12 months. The 6-week period actually frequently can occur while the patient is still admitted to the hospital. But at these points, we assess for our primary outcome measure, which is the presence of moderate to severe depression per the Patient Health Questionnaire 9 form. And simultaneously, we are having patients collect salivary cortisol. This is done twice a day for 2 days in a row so that we can look at not only absolute value of cortisol, but also diurnal variation, as there is evidence that depression is also correlated with a loss of diurnal variation. We began enrolling in November. We have screened 24 spontaneous subarachnoid hemorrhage patients, 17 of whom had aneurysms as the source of their hemorrhage. We excluded some because of the presence of a mycotic aneurysm, poor presentation and prognosis. 2, we were unable to access CSF. 2 presented outside of the time frame, and 1 was non-English speaking, which left 7 eligible patients, 4 of whom we've enrolled, and 1 of whom is pending confirmation of enrollment. This is just a very brief table on the demographic and clinical data of our initial 4 subjects. The distribution falls roughly in line with what we'd expect, and we have reached the 6-week time point for depression assessment in 2 of our patients. And you can see the median is 9.5, which is really the cutoff between mild and moderate depression. So ultimately, I hope that this research can help prevent mental health sequelae and improve quality of life for our cerebrovascular patients. I think overall, I'm encouraged by our results. We were stuck in IRB review for the first 6 months of the research year, trying to finalize study design. But since we've started screening patients, we have enrolled over half of those that have been eligible, which is really encouraging. In the future, I think that there are a tremendous number of exciting opportunities to expand this research. The most obvious is to look at additional populations such as ischemic and hemorrhagic stroke. I think that we can also target a better understanding of how exactly the HPA axis is dysregulated. It would be very interesting to start to look at imaging correlates, to look at whether there are anatomic and structural changes that we can see in regions of the brain where there are high CRHR1 levels of expression. And then while the subarachnoid hemorrhage patient population is not huge in terms of a societal impact, ischemic stroke really is. And so looking at cost effectiveness and societal impact of effective treatment of depression after cerebrovascular injury and improving, for instance, return to work is a really interesting vein of research. I have many people to acknowledge and thank for my work: Dr. Ellenbogen, Dr. McDonald, Dr. Ogeman, Dr. Levitt, Dr. Visse, Dr. Dubovsky, Dr. Hoofnagel, Dr. Shaker, and the whole SANS lab, Emma, Ale, and Doe, have been indispensable. I wouldn't have been able to do this without them. And I will take questions.
Great work. Dr. Robin Pei had his hand up.
Hi, Kate. Very nice work. Quick question. Do you think it would be a good idea to also include controls of, for example, people who get prophylactic EVDs for other procedures, essentially patients who did not suffer subarachnoid hemorrhage, who don't have a history of depression and are not expected to have a history of depression, as kind of like also a sample control for your CSF samples?
Yeah, I think that that is a fantastic idea. It'd be a little bit difficult to find that patient population, like patients who are not undergoing a trauma, but who have a presence of an EVD catheter. I mean, like externalized shunt patients, but that, you know, there's an infection.
Or even lumbar draining, or, you know, patients who don't necessarily have the exact clinical profile as the patients here.
No, absolutely. I was just talking
sorry,
about.
let me just challenge that. What neurosurgical condition does not have a high incidence of depression?
So, Dr. Ogeman, to your point, that is true. The rate of depression really appears to be applicable across critical illness. So if you look at the post-critical illness literature, post-stroke depression, post sepsis, post-ARDS, post-heart attack, it all falls at about a third of patients. There is a higher risk of depression after critical illness across the spectrum. And so identifying a patient population with access to CSF who is not experiencing a critical illness, I agree, would be difficult.
But also, I think in your analysis, you probably have a threshold for definition of depression. So, I mean, we could all argue that we all suffer from depression one time or another. But I think the depression that you're talking about after such a horrendous clinical event is probably at a different scale than, for example, somebody who comes in with a CT angle tumor and disequilibrium and is getting basically like an elective surgery. They may have, some degree of acute depression, but the type of depression that we're talking about, which impacts their life and getting back to their job and all that, would be different. I just think that having a sample size from one patient population and no control, I think it would be better to have some sort of control.
Yeah, absolutely.
I think so. Sorry, go ahead. Andrew has his hand raised. Dr. Coe.
Thanks, Mike. Great talk. Yeah, it's kind of in the same vein as what Dr. Robin and Jeff had mentioned. Do you think there's something different about an acute, sort of one-time event leading to illness versus something like temporal lobe epilepsy at CRHR1 and HPA axis are pretty well a link between those pathologies is pretty well established as well. That's more of a chronic situation where there's been work done on sort of more structural, anatomically specific interactions. I'm just wondering if that kind of, I mean, is there a thought that this is a specific thing to subarachnoid hemorrhage or ischemic brain injury versus something that could be sort of delineated looking at patients where honestly, I mean, we have more imaging, we have more sort of longitudinal data in, say, epilepsy patients, and just wondering if that could be another, because the incidence there is actually probably higher than a third of these psychiatric diseases.
So to answer your question, Dr. Ko, we don't know whether there is something unique to stroke that predisposes patients to develop depression or if it is critical illness. And I think that's actually where a lot of the post-stroke depression literature is trying to go. There's very conflicting data because patients who have TIAs have an increased risk of depression, and you wouldn't that is not a life-threatening critical illness. So there does appear to be something about ischemic stroke that is influencing the risk of depression, but we also we see this increased risk of depression, like you said, across patients who don't have it. So the data about the HPA axis points to some interaction between stressors being a trigger for then developing this chronic dysregulated hypercortisolemic state. But I think that relationship and how it ties to chronic stress versus an acute trauma and stress versus the ischemic pathology of stroke, all of that has yet to be explored and understood.
And just really briefly to speak to the control group conundrum. So in this case, there's two different interactions going on. So there's a genotypic interaction, which seems to be a pretty strong one that modulates the stress response for the depression or mental health response after a significant stressor. And that can be a single stressor or a chronic stressor. And that's the genotype analysis that has been done that we're doing. And then there's a disease-related or patient demographic or factor-related influence. So you would think that patients who come in at a worse Hunt-Hess grade would have a higher incidence of depression, but that's actually not the case. It's not related to Hunt-Hess grade or severity, not in any particular way, but there is a range of responses that relate to things like female sex, the younger patients do worse, they have more depression. Some things that are obvious, like a new neurological deficit, but other things that aren't. There might be an anterior versus posterior circulation aneurysm effect. So there's disease-specific things that we can try to tease apart that don't require a control, because we know there is an effect of critical illness on depression. I think the danger with a control group is probably the difference between the depressive effects of a control group, like a tumor surgery and stroke. There probably is maybe a difference, but the difference is small. And in order to capture that, you would need a very, very large sample size. And the heterogeneity of that control group might make drawing conclusions difficult. I do want to move on, though. I know this is an interesting topic, and Kate kind of created this whole concept. I do think that there's a lot here that we ignore as neurosurgeons, as far as the impact of mental health and probably disease-specific effects on mental health that we don't really consider in many cases. And so actually this particular concept, this was something that Dr. Kim brought up to me when I was a resident, is all my patients, subarachnoid hemorrhage, so many of them come back and they're depressed even if they did well. And this is a theme that we see over and over. So more to come. And now I'd like to introduce our next speaker, is Dr. Jessica Eaton, who attended school at University of Louisville and is going to speak to us about her research project. And I don't want to take any more of her time, so Jess, take it away.
All right, thank you very much. So good morning. Thanks for the opportunity to present. My time during my protected research here was spent in Dr. Ferreira's lab, focusing on the genetics of skull-based tumors in general. This morning, I'm going to talk about a very exciting project on skull-based chondrosarcomas aimed at investigating a potential therapeutic target. So by way of introduction, chondrosarcomas are tumors that arise from the chondrocytes in the synchondroses. Skull base is only involved in about 1% of chondrosarcomas, and these make up only about 0.15% of all intracranial tumors. They tend to be indolent, but can be up to WHO grade 3 and can be very locally invasive. So current best treatments are maximal safe surgical resection. Adjuvant radiation is only used for grades 2 and 3 tumors, although studies have only consistently shown that surgical resection has an effect on outcome. There's no established role for chemotherapy, and generally survival time in these patients is about 10 years. So this project was born out of treatment of 2 chondrosarcoma cases that were patients of Dr. Ferreira's and then co-managed by Dr. Lee Cranmer, who's the head of the sarcoma center at the Fred Hutch. This first patient is a 58-year-old female who initially presented in 2012 with diplopia and restricted visual fields. She was found to have this extradural mass and underwent a subtotal resection at an outside hospital. Path was grade 2 chondrosarcoma. She had adjuvant fractionated radiation. So these are her pre and post-op images from that first surgery. And then in 2020, she re-presented with diplopia, had recurrence that is shown here, and underwent craniotomy with Dr. Ferreira. She had some wound healing issues afterwards and actually went to the OR at the beginning of this month for a rotational flap. But most importantly, the highlight was that the patient was started on ivosidenib in July of 2021. So these initial scans show stable disease, but the most recent scan actually shows some involution of the tumor, which is this scan down here. Currently, she's tolerating the medication well, and she has no neurodeficits. This is another case of a 61-year-old female with Olier's disease, which is a syndrome that causes multiple benign enchondromas. These patients are also at increased risk of other tumors, including malignant transformation of their enchondromas into chondrosarcomas. She initially had a surgery for a skull-based chondrosarcoma in 1988, and then had repeat craniotomies in 2004 and 2005, and then had gamma knife with Dr. Rockhill for a recurrence in 2013. So this 2013 image is actually the first one that we have in our system. She re-presented in 2020 with retroorbital pain, face pain, and vision loss, and underwent craniotomy for resection and an optic canal decompression with a new patella, and then was trialed on pembrolizumab in late 2020. Actually had a slight increase in her disease on imaging, so she was taken off of that. And then in July of 2021 was started on ivosidenib, and again, scans have been stable to slightly improved, with this being the most recent scan, and there is some involution of the tumor on the most recent scan. So IDH is isocitrate dehydrogenase, and it's an enzyme in the Krebs cycle. Point mutations are common in several types of tumors, including cholangiocarcinomas, AML, chondrosarcomas, and gliomas. Point mutations in these tumors are gain of function mutations, which reduces alpha-ketoglutarate to 2-hydroxyglutarate. This interferes with normal cell differentiation and promotes tumor formation. IDH1 mutations, as we know, are very well studied in gliomas and generally affect amino acids at codon R132. The most common variant in gliomas is R132H, followed by R132C. And I'll show you later in our data that these are the same variants that we found in our chondrosarcomas. So IDH1 mutations were initially thought to be an ideal therapeutic target because tumor evolution studies have shown that the mutations occur very early in tumor formation, and it was therefore thought that this could be one of the main drivers of glioma formation. However, over time, there have been in vivo models of gliomas that have shown that IDH1 mutations on their own are actually not sufficient for tumor formation. There has to be additional mutations to drive glioma formation. So ivosidenib is a mutant IDH1 inhibitor. This diagram shows the mechanism of action. As we said, the IDH mutation reduces alpha Kg to 2-HG, and 2-HG interferes with normal cell differentiation. The drug blocks the action of the mutant enzyme to prevent accumulation of 2-HG and allow for normal cell differentiation, which stops tumor growth, theoretically. In 2013, these types of inhibitors were shown to be effective against glioma and leukemia cells in vivo. And then clinical trials of AML specifically were then successful. And so ivosidenib is now FDA approved for refractory and relapsed AML. However, in gliomas, while the drug prevented 2-HG accumulation, it actually didn't affect glioma cell proliferation. And with long-term treatment, actually accelerated glioma cell growth and shortened in vivo survival. So the thought is that the difference between AML and gliomas is that IDH mutations are required for leukemia cell proliferation, which is not the case in gliomas. It's thought that actually IDH mutations create a favorable environment for other mutations to drive tumor proliferations at the start of tumorigenesis in gliomas. But later in the tumor's life, it seems like IDH mutations are actually passenger mutations and not actually driving tumor proliferation. So therefore, blocking IDH actually doesn't do anything to affect glioma cell proliferation. So IDH1 in chondrosarcoma specifically, there are some small studies of IDH mutations, but these do not specifically pertain to skull-based chondrosarcomas. So one study of 88 head and neck chondrosarcoma showed that IDH mutations occurred in 64.5% of these tumors. There's a higher proportion in Olliers disease, 90% of patients. So it's thought that IDH might be a predisposing mutation that allows enchondromas to undergo malignant transformation to chondrosarcomas. There was also a small cohort of chondrosarcomas in the phase 1 clinical trials of ivosidenib, and 55% of those patients had stable disease on imaging. But again, these were not specifically skull-based chondrosarcoma patients. So we have a cohort of 38 skull-based chondrosarcoma patients, most of whom have tissue in the tumor bank. So far, we have clinical data on all 38 of the patients, and then we have whole exome sequencing on 32 tumors from 28 patients. And we have additional whole exome sequencing pending. So this is a very brief overview of some of our clinical data. On average, patients are about 45 years old, half men, half women. Most have subtotal resections. Most patients did not receive radiation, and about 40% of the cohort needed a second surgery. 83% of the tumors were grade 2. Most were primary skull-based tumors, although 4 of our patients were metastatic tumors from another primary chondrosarcoma somewhere else in the body. And then our progression-free survival was about 4 years, and mortality was about 15%. And this is our preliminary whole exome sequencing data. We're going to do much more extensive analysis once we have all of the exomes. What we've done so far is just to look at what we have in terms of IDH1 mutations and TP53 regulating kinase mutations. So 75% of our tumors have IDH1 mutations, 44% have TP53 mutations, and 38% of the patients have both. And then these are the specific amino acid changes from the IDH1 mutations. So the most common variant in gliomas is this R132H, which does occur in our samples, but is not the most common. R132C does occur in gliomas, but it appears to be just at in this very early stages more common in our chondrosarcomas than it is in gliomas. So this is a very brief analysis that's pretty limited by the current number of samples that we have, but these are univariate logistic regression models with the outcome being mortality. IDH1 and TP53 mutations both appear to trend towards a decreased odds of mortality, but neither is significant. And again, not significant, but the most significant thing that we have so far is that tumors with both mutations could have a decreased odds of mortality. So what does all of this mean? The clinical response from these 2 patients is very exciting, kind of gives us a starting point for investigations into whether IDH1 might be an effective target for treating skull-based chondrosarcomas. It does make sense as a therapeutic target, but it is very likely not that simple. The viability of IDH1 as a target is probably dependent on the tumor having other mutations. So there are a lot of questions left to ask and details left to look at. So to answer these, we're doing more whole exome sequencing. We've also started doing single cell RNA sequencing, particularly focusing those resources on patients that have been treated with the drug. And so we can look at their tumors before and after treatment, or patients that had surgery multiple times. And so we have tumors from throughout their disease course, so we can look at evolution of the tumor over time. And then finally, the lab is also culturing cell lines that we hope to use to analyze the effects of the drugs on the chondrosarcoma cells. These are my references. Thank you very much to everyone in Dr. Ferreira's lab who has been very awesome in teaching me a lot of stuff that I did not know before I started this year. And then Dr. Cranmer at the Sarcoma Center at the Fred Hutch for helping us manage the patients.
great talk, Jess, and open up the floor to any questions.
Yeah, can and I may have just missed this, but the IDH mutation, if present, bodes well, or that's the thought that it bodes well. And they also respond to a treatment targeting that mutation. Is that right? Because that seems like it's I guess it just seems like the opposite from gliomas.
Yeah, so the very, very early, and I'll say we don't have enough data to say anything for sure, but it looks like in our cohorts that it is a favorable thing to have an IDH1 mutation. The chondrosarcoma at-large literature and central chondrosarcomas, meaning like spine and ribs and pelvis, and peripheral chondrosarcomas, some of it's kind of split in terms of the outcome. Some of them say that IDH1 is favorable, and some of them says that IDH1 is not favorable. So I would say at this point it's pretty unclear. And in skull-based chondrosarcomas specifically, it hasn't been looked at all.
This is Manny. To go along with that point, that's a very good question, Andrew. These are extremely rare tumors. The prognostic value and the mutation status is, like Jessica said, unknown. And the response to therapy, literally, these are the first two chondrosarcoma skull-based patients ever treated with this particular drug. It's supposed to be a targeted therapy, right? But as we all know, all of these IB drugs are quite dirty. So we have 2 out of 2 patients that responded. Both had the point mutation in the hot spot that has been correlated with responding to the drug in the 2 other diseases, AML and cholangiocarcinoma that Jess mentioned. In chondrosarcomas of the skull base, we still don't know if wild type IDH1 mutant patient or non-mutant patients would respond, because it's theoretically possible that the drug, again, being dirty, could have other targets. And that's where her research with the single cell sequencing and these drug lines with specific mutant tumors will essentially dive into mechanism. But to see a drug respond like this and essentially make the tumor melt away is very exciting. What Jessica also didn't mention is that one of the patients is actually a germline Olier's patient. And this was specific therapy that made the tumor of the skull base respond, but not her peripheral tumor. So there's something here that's quite exciting.
That's great, thank you. And I think we'll moving on, last but not least, is Dr. James Pan, who joined us after his undergraduate degree at Carnegie Mellon in Pittsburgh, whose school colors are plaid, and then on to Stanford for medical school. And with that, since we're trying to stay on time and people are doing an excellent job staying on time with good questions, Dr. Pan, take it away. You are muted, sir.
Great job so far.
Dr. Ellenbogen, you look very presentable. And you are muted now too.
The
All
2
right.
doctors were all dressed up, all 3 doctors. Well, James almost dressed up. Go ahead,
Just
James.
dressed up as he gets.
All right. Okay, hopefully this works now. Thank you for the introduction, and everyone, thank you for having me. So today I'll be talking to you about mobility in the brain. So it's essentially looking at the concept of patient mobility as a diagnostic and therapeutic marker for neurological disease. And since this is kind of a tech-focused talk, I'll do the fashionable thing everyone's doing for their talks today, and have to mention ChatGPT. So the question I asked it is, why should we care about this? The question I asked is, why is mobility important in the evaluation of neurological disease? And, this is what the AI had to say. So it's important because it's closely related to the functioning of the nervous system. A lot of neurological disease manifests in symptoms such as tremors, weakness, stiffness, and problems with their balance and coordination, and therefore assessment of a lot of these factors is important to making diagnosis and also figuring out what kind of treatments and how patients respond to these treatments. And I largely agree with that, and I think it makes intuitive sense from a surgeon's point of view. Is that patients that move more tend to be healthier, and after you operate on a patients that have higher levels of mobility tend to have better outcomes, and patients that have better outcomes also tend to have better mobility. So it's a kind of a reinforcing topic that you want patients to do better and move more after they get treated for their various conditions. So I wanted to pick a neurosurgical disorder to study mobility, where mobility is an important topic for both the diagnosis and also monitoring how the disease responds to treatment. And that disease is idiopathic normal pressure hydrocephalus, and as many of you are familiar with, it's the most common form of hydrocephalus in adults, and you have the triad of gait disturbance, cognitive decline, and urinary incontinence. However, those three symptoms by themselves aren't super specific for NPH, as people in this age group can have these symptoms for a variety of other reasons. Therefore, the diagnosis of NPH requires a careful medical history, physical examination, review of neuroimaging, and parts of the exam and the history have specific deficits in the patient's mobility as it relates to the gait. Definitive diagnosis is made with things like a lumbar puncture, a lumbar drain trial to see if they would respond to things like a shunt placement. And of course, treatment of NPH is with a VP shunt, but interestingly, only about 60 to 80% of patients improve after shunt surgery, which makes us question, are we diagnosing this condition in the most optimal way, given how we're doing things now? So the issues with how NPH is diagnosed right now, again, as I alluded to earlier, was that not all patients improve after shunt surgery. So this calls into question the sensitivity and specificity of current diagnostic methods. The current evaluation is only done in one office evaluation, so has low temporal resolution. It also privy to a Hawthorne bias. Do patients perform differently because they know that they're being observed in the clinic? Is there some sort of delayed response to CSF drainage when you do a lumbar puncture or a lumbar drain trial? And also, we like to understand the natural history of the improvement trajectory after shunt placements. So, we see them at specific time points after they get the surgery, but we kind of don't know what happens in between. And kind of knowing a higher temporal resolution can help us better understand how patients respond to treatment, and also how to intervene earlier on if things don't go correctly. So the thing that I used to track mobility, and the thing is, mobility has been studied in the context of NPH, spine disorders, in the past, and has found to correlate with surgical outcome and things like PROMs. But all those studies use things like a commercial pedometer, something that the patient had to bring home. Not everyone had it. In this study, I was looking at the utility of using commercial consumer devices to monitor a patient's mobility and how they're walking and how they're moving around. And I use the iPhone for this, and this is a device that many of us have. And believe it or not, your iPhones actually collect a lot of data about you regarding, again, how fast you're walking, how many steps you're taking, the length of your steps, how steady you're walking, and so forth. And a lot of this in the iPhone sensors has been validated against a gold standard pressure mats, which is the gold standard for measuring how you're walking. So what we did was we went to the NPH clinic. We enrolled a bunch of patients and also healthy volunteers that were being evaluated for the diagnosis of NPH. We enrolled 8 patients that were being considered in the NPH workup process. 2 of them eventually underwent shunt surgery, and then we also recruited so far 3 healthy volunteers. And then across these 11 people that we've been collecting mobility data on, we've collected almost more than 1 million data points across the length of the study. So this is just some basic demographic and baseline clinical characteristics between the two groups. We have of these two groups. I wanted to give you a kind of a sample case of a patient that was enrolled in the study, got his treatment for NPH, and wanted to show you what some of that data looks like, and see how this can help us in the visualization and better understanding of how these NPH patients do. So this is a 65-year-old man that came into the NPH clinic for about a year of gait disturbance and cognitive decline. He was also found to have ventriculomegaly on his neuroimaging studies. So when he first came in, he actually did quite well. His gait was pretty normal. He had a good MoCA score, and he was given the diagnosis of possible NPH. So it's someone that could have NPH, but it's not a slam dunk diagnosis. But over the course of 1 year, he continued to decline. We reevaluated him and thought that maybe this is NPH. So we here's what a scan looks like. We gave him a lumbar puncture in the clinic, did a high volume tap, and then this patient improved in his gait later that day. So we thought that this would be a ideal candidate for a shunt. So this patient underwent a right frontal VP shunt placement per our standard protocol, had a Certus valve inserted at 4. And he enrolled in the study, and then we monitored his gait in the ambulatory setting at home to see how he did. So this is data from this patient. So looking at these different metrics for how this person is walking, you can see that there has been an improvement in his walking speed and also his step length over time. You can see this line there that delineates his baseline gait characteristics, and to the right of that is how he's been doing post-operatively. Interestingly, things that weren't affected were his double support time, meaning the amount of time that that both feet are on the ground, and also his walking asymmetry, which is kind of more of a proprietary measure developed by Apple, that has a lot greater variation. If you look at how many total steps he takes, it's a lot more variable. I don't think it's a great measure of overall mobility, because it's highly dependent on how often you bring your phone with you. So if you're not carrying your phone with you that day, it won't register the number of daily total steps that you're taking that day. Whereas the other metrics, things like step length and walking speed, it's an average of the measurements for when you do have the device on you. So it's not dependent on how often you carry the device on you. And then if you look at his 6-minute walking distance, you can see that's also improved quite a bit after his shunt surgery. So a couple of things I learned from this is when we get these patients generate a ton of data, and during the analysis, the data is not as clean as expected because there's a lot of variations in how people use their phones, use their devices. They might not carry them on them all the time. And there's a lot of variability that you have to account for when analyzing this data. There's also been some challenges with enrollment. So a lot of the challenges that we've had is, people don't speak English, they don't have iPhones, which the study is currently designed for. They forget their phones at home, or when we try to install the app, they're unable to download the app from the App Store, mostly because they forget their passwords. And unfortunately, this whole password process isn't a very user-friendly experience, especially for the older population. The variability in the data collected on the smartphones we'll eventually need a large number of patients in order for it to converge to a consensus of exactly what these patients look like. And again, daily steps, I don't think was a reliable measure of mobility when using consumer devices. And again, that's a function of how these patients, have their devices on them at any given time during the day. So next steps in this study, we want to continue enrollment and data collection for these patients. We're going to collaborate with the data scientist for eventual downstream analysis. And also I'd like to integrate PROMs to validate some of the mobility data to see, if this increase in mobility actually affects the overall quality of life, disability, and ultimately outcomes after the surgery. To finish up, so I'd like to thank a few of my mentors, so Dr. Bono, Dr. Hofstetter, Dr. Williams, and other members of our staff that that's really helped me develop this idea of using mobility to track how these patients are doing after these surgeries. Thank you.
Boy, what a great morning this morning with the three Utes that just spoke. Take it away, Dr. Levin.
No,
Yeah,
go ahead, Dr. Hofstetter, please. That was what I was going to call on.
Oh, no worries. Hey, thanks for presenting the data, James. Super nice. I have a question for you. You mentioned integration of PROMs here and how we can link those together. So tell us a little bit about how you think that impacts and how that's going to change medicine and how we can learn from this to better monitor our patients. So what is your vision for this?
Yeah, I think a lot of we kind of only see what our patients are doing at specific follow-up points. So at the prescribed follow-up points, 2 weeks, 3 months, 6 months, but we're kind of unsure exactly how the patient is doing in between. And again, like the mobility data, you kind of have them carry the device and and it observes them on a high resolution. But if we can also figure out their overall state of health, the overall state of disability from the patient-reported metrics, I think that would also give us a much better idea of the overall of the patient's overall health. And I think doing that digitally makes a lot of sense because right now the way that we do PROMs for the in spine world, like you and I are very used to, it's all done via paper forms. But if we can all move that to a digital experience, I think we can collect a lot more data and also have a lot better idea of a patient's overall health and trajectory, in addition to around. And I highly suspect that they're highly correlated with each other. I think patients with high qualities of life will tend to move more and move more efficiently.
I mean, one interesting thing is, to think about is, Apple actually stores the data for 6 years. So for example, Kate's experiment, I'm sure depressed people walk less. So I think anybody with a subarachnoid hemorrhage would be nice to kind of, get the data from their phone and see if, how they changed. Again, you have, pre-event data on all these patients. There's a very prominent Canadian researcher, and she actually found that the number of times you charge your phone is very much correlated with your well-being. So other people, it's almost like, you don't groom yourself and you're not active. So the number of times you charge your phone indicates, how happy and how good your well-being is. So just Kate, if you're still on, this might be something, some data, a treasure that you have not lifted yet.
Yeah, absolutely.
Dr. Melanie.
I was going to say that there's some work on devices that might be a really interesting correlate around shoe, believe it or not, shoe insoles, like things that you put on the bottom of your shoe that speak to your, whatever. And I think that they were developed in this, time of telemedicine when we couldn't get full neuro exams. They can be designed to get everything from a Babinski to, differential gait balance, things that might be very interesting. And so I think that further development of things like that in the neurosurgical and neurology population might be really interesting over the longer term, because there's a lot of non-specific things you can get from your iPhone. But I think if you're looking at gait, some of the cooler things might be around the helping design some of these cool insole, telemetric insoles that would communicate with your iPhone, but give it more robust information specifically about what you're looking for.
There's been some really cool things done. I was speaking to some rehab doctors, and what they're doing is, they're using the microphone on the iPhone. When you put it down on your desk, you do some rehab, range of motion exercises, and the microphone's somehow able to pick up like how the sound waves are bouncing around in the room, and uses that as a proxy measurement to interpolate your range of motion and how well you're rehabilitating through their, exercises, which again, I think will be very applicable to neurological rehabilitation for a lot of our patients.
I think James has done a really good job with this. I think it's really, as we've talked about, it's kind of a treasure trove of untapped data. I think one of the other interesting questions that we've sort of yet to tackle is, how can you use this to differentiate patients who we think have the disease from those who don't? Hopefully further analysis will help us kind of tease that out, because right now it's really cool data, but it's showing us stuff that we largely already know. But so trying to find out if we can help in the diagnosis of NPH and other gait mobility disorders would be great. And obviously having continuous outpatient sort of ambulatory data is very helpful, above and beyond the data that we collect in clinic, because there is a lot of suggestion that there's a bit of a Hawthorne effect where you when you measure something in these gait disturbed patients, you wind up catching stuff that's maybe a little bit different from their day-to-day life.
Yeah, Rob, I think that's a really good point too. As kind of you see in this chart, the walking speed that you have, at home is actually a lot slower than, the walking speed that we capture when they're in the clinic. So, I do think there's a coaching aspect of it when we measure these things in clinic that could change from how these patients really behave in a home environment.